Thank you, Jeff. Thank you for the scientific committee for this invitation. I'm really happy to be part of this exciting meeting. And my task will be to try to integrate this fatal triple linking obesity, type 2 diabetes, and NASH. As you said, I'm a professor of nutrition endocrinologist, and actually the patient that I'm seeing every day has obesity, type 2 diabetes, and NAFLD or NASH. And you'll see that it's not always an easy task to combine everything and also try to understand what is their individual risk for each individual diseases. So I will try to take you over this issue. These are my disclosures. So as we already said, and as Zober told us previously in his epidemiological round trip around in the global prevalence of all these diseases, there is a strong prevalence of all these three metabolic diseases worldwide: obesity, type 2 diabetes, and NAFLD. And what we see also is that there's not a complete overlap between these three diseases. We have patients with obesity that does not have NAFLD or type 2 diabetes. You are seeing in your hepatology clinic patients with NAFLD without obesity and without type 2 diabetes, even though it's very prevalent. And there's also type 2 diabetes patients without obesity and without NAFLD. So it's not always easy to try to understand what are the drivers of all these three metabolic diseases. And as there are a triple fatal diseases, this triple interaction is not also easy to address. So the way I wanted to address this issue is to start with the link between obesity and NAFLD. As we are all aware, obesity is an independent risk factor for NAFLD. There's a very high prevalence of NAFLD, and especially in obese patients with BMI greater than 40 kilograms per meter square, and goes up in bariatric surgery cohorts up to 92%. And we also know, based on some meta-analysis and systematic review, that there's a very significant increased risk of NAFLD. We have an estimate based on a meta-analysis that has been assessed up to 3.5-fold increased risk of NAFLD in patients with obesity compared to patients with normal weight. I'm not sure this is really accurate, but at least we have some estimates that can help us understand the link and the risk of NAFLD between obesity. On the other hand, in the meta-analysis of the global prevalence of NAFLD, when we look at the prevalence of obesity among the patient with NAFLD, it goes up to 51%, and in the patient with NASH, the prevalence of obesity is even higher, up to 91.93%. What about the association between NAFLD and type 2 diabetes? Again, you've seen this slide previously. We have data from a large meta-analysis, including over 80 studies worldwide, that tells us that the prevalence, global prevalence of NAFLD among patients with type 2 diabetes is approximately 55.5%. And as we've talked already, the most difficult part when you want to assess the prevalence of NASH or advanced fibrosis is the diagnostic methods. Of course, we don't have liver biopsy for every patient with type 2 diabetes. You see here that in previous study performed in patients with type 2 diabetes and liver biopsy, in this panel, the prevalence of advanced fibrosis or the prevalence of NASH has been reported to be very, very high, up to 50% of advanced fibrosis. But these studies were probably biased because they included patients with an indication of liver biopsy, so probably largely overestimated. On the other hand, when you look at a study that's been performed in UCSD, including patients with type 2 diabetes in the primary care setting, and you screen them using another non-invasive diagnostic tool such as magnetic resonance elastography, you can see that the prevalence of NAFLD is around 65%, and the prevalence of advanced fibrosis based on this biomarker is much lower, around 7.1%. And based on the meta-analysis, but again, including only, I think, something like 10 studies with liver histology, we meet somewhere in the middle. The prevalence of NASH among patients with type 2 diabetes is estimated to be around 37.3%, and the prevalence of advanced fibrosis is estimated to be around 17%. So it's not really clear, but clearly you have a population, type 2 diabetes patient, which is a high-risk population for advanced stage of disease, NASH and advanced fibrosis, and I will come back to this later. What I wanted to highlight today is also the link between NAFLD and the increased risk of developing type 2 diabetes. It's been, over the last decade, main question regarding chicken and eggs, which disease comes first. And now we start to have very nice data that have been put in this meta-analysis, including 33 observational studies, over 500,000 individuals, mostly men, 62% of men, mean age 47 years, coming from very different regions around the world, Asia, Europe, and USA. You see that the prevalence of NAFLD in this meta-analysis is around 30% of NAFLD. And the longitudinal follow-up up to 5 years were able to capture 29,000 cases of incident type 2 diabetes. And what it tells us is that the risk of incident type 2 diabetes in patients with NAFLD at baseline without type 2 diabetes is twofold higher compared to the patient without NAFLD. So this is clearly something that we need to take into account. You have also a very increased risk of developing type 2 diabetes if you have a patient with NAFLD. I would like to take a small look at also the severity of the disease. Here you see it's still the same meta-analysis. The image is pretty hard to read, but it's only including, what you need to see that it only include very small studies, only 4 studies that have assessed the severity of steatosis, uses ultrasound, which is not the most accurate biomarker for the quantification of liver fat. But still, in these studies, there's a signal showing that the severity of hepatic fat content of steatosis is associated also with an increased risk of type 2 diabetes. And so I think, although the hepatology field is moving to say that hepatic fat may not matter, it probably matters in the context of the global metabolic risk of the patient. And it's the same thing when you try to look at the severity of the disease based on the stage of fibrosis. Again, it's a meta-analysis. There's limitation. There's only 4 studies, including with histological results. But it seems that the severity of NAFLD also increases the risk of development of type 2 diabetes. So if we want to look a little bit further in this and try to assess the potential causality between the two diseases, I just wanted to point out this study that was included in the meta-analysis I just showed you. It included patients, a small number, 121 patients with biopsy-proven NAFLD, with a very large follow-up. This is a study from Sweden. And the patient had a follow-up at 13 years and up to 28 years with repeated liver biopsy. You see here nicely, as I showed you in the previous slide, that the grade of steatosis is associated with a significant increase of incidence of type 2 diabetes. But also, what is interesting in this study is that the few individuals that had a repeated liver biopsy and improved the stage of steatosis reduced significantly their risk of developing type 2 diabetes. So in a way, if you have a high quantity of liver fat, you have an increased risk of type 2 diabetes. If you're able to decrease this quantity of steatosis, then you will be able to decrease your risk of having type 2 diabetes. And this has been also shown in another study coming from Japan. This is a retrospective study. So again, there's some limitation. It's a pretty large number of participants, 3,000 patients. These are data from healthcare data. You see that 700 patients had NAFLD, 2,346 patients did not have NAFLD at baseline. And during a follow-up of 10 years, there's approximately 100 patients that improve steatosis. This has been assessed using ultrasound again, so not the most accurate technique, but still you see that the patient that improved NAFLD based on this ultrasound assessment had a strong and significant reduction risk of incidence of type 2 diabetes, and this remains significant even in a multivariable adjusted model. And they went a little bit further and look at the one that increased their BMI or decreased the BMI, and the results stand still significant, which means that probably even if the BMI is not changing or even not decreasing along with the decrease of hepatic steatosis, you will still be able to decrease your risk of type 2 diabetes. So this is something that I think it's important and also shows that there's a strong causality potentially between the two diseases. Now, let's move to the relationship between obesity and type 2 diabetes. This is also well known that a patient with obesity has an increased risk of type 2 diabetes. But what is the impact of NAFLD? In other words, is it NAFLD that drives the risk of diabetes? It's really hard to address this question, but I wanted to show you a very recent data from an epidemiological study from the multi-ethnic study atherosclerosis, the MESA, including over 4,000 people, adults, with a mean follow-up to 9.1 year. And what they did is they showed that patients at baseline with obesity has an increased risk of developing type 2 diabetes with an odds ratio of 4.5. And through statistical assessment, they were able to determine that the effect driven by the presence of NAFLD at baseline, assessed with CT scan, was approximately around 36%. So not that much. 36% of the incident cases of type 2 diabetes could be mediated by the presence of NAFLD. So I don't know if this study is accurate, but I still it's one study that can help us understand that you have an overlap between three diseases: obesity, with a high risk of NAFLD that himself leads to a high risk of type 2 diabetes. And probably there's an interaction, but it's not exclusively linked all together, and there are several pathophysiological pathways. And this is one of the hypotheses. The clear pathological pathways are not clearly understood yet, but there's a lot of hypotheses, and for the sake of time, I won't go over this in detail, but it has been recently reviewed by the group of Targer, and if you want to go a little bit further in this question, you can go and look in this very nice review that tackled the link between NAFLD and type 2 diabetes. Briefly, what we know is that there's an alteration in the lipoprotein and dyslipidemia, genetic variant in PNPLA3 and TM6SF2 also is probably at stake, and the increase of hepatic glucose output and decrease in insulin clearance, as well as an increase in VLDL secretion in the liver, could lead also to an alteration in the bile acid profile, and all this alteration could explain why patient with NAFLD has an increased risk of type 2 diabetes. And finally, in the first part of this presentation, as I told you, there's not a complete overlap between NAFLD, type 2 diabetes, and obesity. So that leads to the concept that there must be diseases subphenotyping based on probable causal relationship. And this has been nicely demonstrated by the study performed from the data in the UK Biobank. This was mainly driven by the genetic analysis. This group has assessed either if you have patient with, let's say, genetic probability of having NAFLD with different variant, and they've been able to define that there's probably in the center the genetic risk of having NAFLD that then will drive your risk for the occurrence of type 2 diabetes and probably obesity. And on the other hand, you have other subtypes of patients that have more like genetically determined metabolic disease, such as type 2 diabetes, that then in turn would lead to probably NAFLD and dyslipidemia. So this is very complex, but I think we really need to better understand the pathophysiology of the different subtypes of patients, because at the end, this is how we're going to be able to move towards more precision medicine and probably personal care. It is possible that we won't treat the patient with the same therapy or combined therapy based on their profile. So this is a new concept, I think, that is really important when we're thinking about all the metabolic disease altogether. It probably needs to be more linked to the causal pathophysiology in order to more define subtype of patient. One patient with NAFLD is not the same than another, and it's the same thing with a patient with obesity, and it's the same thing with a patient with type 2 diabetes. So in the last part of this presentation, I wanted to talk about the bi-directional relationship. I took a lot of time to show you the risk between obesity leading to NAFLD that increases the risk of type 2 diabetes, but the other way around is also true. And obesity and type 2 diabetes are known to increase the risk of progression toward advanced stage of NAFLD. So these have been previously reported in a number of studies. Here is the natural evolution of NAFLD, and clearly obesity and type 2 diabetes, as I've showed you also in the previous slide regarding epidemiology, are considered high-risk population with a higher risk of NASH. The prevalence is approximately between 20 and 30%, and this patient has also a higher risk to progress to advanced fibrosis, cirrhosis, and even hepatocellular carcinoma. In regards to obesity, there's not a lot of study that clearly links the risk in the progression of NAFLD, because it's so the association is so strong that it's sometimes difficult to try to analyze one factor after the other. But clearly, one study performed by Annes Engström in Sweden shows us that the exposure to obesity has a strong impact to the prognosis of liver disease. Here you are seeing the figure from the baseline BMI of over 1.2 million Swedish adolescents enrolled in enlisted for the conscription. And they have been followed up for a very long period of time, leading to a 34.8 million person year. And you can see clearly that the higher the BMI is, the risk of severe liver disease is also increasing. So there's a strong impact of the exposure to obesity even at the late stage of adolescence. And the study also shows that the same impact, increased BMI at late adolescence, predicts the risk of hepatocarcinoma cellular. So it's a strong evidence of the role of obesity and the interaction with chronic liver disease and potentially NAFLD. On the other hand, there's also strong evidence of the bidirectional relationship between NAFLD and type 2 diabetes. When you are in your hepatology clinic and you're taking care of a patient with NAFLD, if he has, on top of that, type 2 diabetes, you know that this patient will have an increased risk of NASH, an increased risk of having advanced fibrosis, and an increased risk of having HCC. On the other hand, when I am in my clinic taking care of a patient with type 2 diabetes, and I know that he has NAFLD on top of type 2 diabetes, I know that the management of the glycemic control will be probably more challenging, and I will probably need to require additional anti-diabetic therapies in order to achieve a glycemic control compared to a patient without NAFLD. And also, it has been shown that there's an increased risk of macrovascular and microvascular complication. Here you see, again, the study from the group of Targer showing that type 2 diabetic patient with NAFLD has a higher prevalence of coronary vascular disease, cerebral vascular disease, peripheral vascular disease, and also when you put all these individual cardiovascular disease all together, there's a high prevalence in patients with NAFLD compared to patients without NAFLD. And this is true also for microvascular complications, CKD, and the non-proliferative retinopathy is also significantly higher. So what about the other way around, and what is the impact when we treat, for example, type 2 diabetes? We know that there are some anti-diabetic therapies that can improve NAFLD severity. Pioglitazone, for example, I'll just show you one slide of the effect of pioglitazone on the resolution of NASH in the study from Caussy with patients with diabetes and prediabetes. There is pretty strong effect of pioglitazone in the resolution and improvement of NASH histology. Semaglutide, we talked about this previously. There's also originally, it's an anti-diabetic drug. Now it's moving to an anti-obesity drug, but it's also I've proven in a phase 2 clinical trial designed for the resolution of NASH that the NASH is improving. And very, very recently, there's another GLP-1 agonist, the tirzepatide, that has demonstrating an improvement in the liver fat content, and it's currently under investigation for the treatment of NASH as well. What is interesting is that both these therapy also have a strong weight loss effect, and we don't know if the improvement of NAFLD and histological feature of NAFLD goes through the weight loss effect, but what is for sure is that weight loss intervention can improve both NAFLD and type 2 diabetes. Again, for the sake of time, it's just an overall summary. We have all in mind this study performed by Romero Gomez showing that the 52 weeks lifetime intervention is able to significantly improve NASH, fibrosis, and steatosis. And if you marry that with the lifestyle intervention that has been performed, for example, in the diabetic program prevention, you see that lifestyle intervention can prevent the incidence of type 2 diabetes. And it's the same for bariatric surgery. We have studies that showing us that there is a significant and persistent resolution of NASH after bariatric surgery, even after 5 years, and it's correlated to the weight loss of the patient. And it's also true for the improvement of liver fibrosis stages. After 5 years of bariatric surgery, you see that a significant distribution of the stage of fibrosis is improving, and it's the same thing, of course, for type 2 diabetes. We can achieve up to 80% of type 2 diabetes resolution after bariatric surgery based on meta-analysis. So here are my take-home messages. Obesity is a major factor for risk factor for NAFLD and type 2 diabetes. Obesity and NAFLD increases also the risk of developing type 2 diabetes, but not exclusively. And this leads to several subphenotypes depending on distinct pathophysiological pathway that we probably will need to address in future to improve the clinical care of our patient. And both type 2 diabetes and obesity are associated with advanced stage of NAFLD, but the strategy targeting obesity improve both NAFLD and type 2 diabetes. Thank you.